All right. Good afternoon, everybody. So my name's Liz Morris. I'm an interventional radiologist at NYU, and I'm going to be talking about the Thrombolex BASHIR catheter today. As everybody in this room knows, PE is a big problem. It's something that you face every day in a large hospital system. And there's a very wide range of how these patients present, and as a result, you have to have a lot of tools to treat them. We heard about the medical management, which is certainly the majority of patients are managed exclusively medically. But as the spectrum of the disease worsens, there are increasingly aggressive measures needed to stabilize and treat these patients, both in the short term and the long term. And so often patients can be treated with an oral medication as an outpatient, but in the more severe cases, these patients are staying in the ICU and undergoing invasive procedures and surgeries. So the categorization systems that we use to classify PE, these are the two ones that we use typically. Use biomarkers such as the BMP, the troponin, EKG changes to delineate patients who have normal blood pressure into either low risk or submassive or low or intermediate risk, and then the presence of hypotension suggests a massive or high risk PE, And as you can see in the chart on the top, there's a corresponding increased risk of mortality as well. So, like we said, low-risk patients, anticoagulation, outpatient versus inpatient. And as we get into the submassive, intermediate-risk patients and the massive patients, there's more of a conversation about what to do with these patients. And a lot of that is driven by, quite frankly, a lack of data on this topic, some of which we're trying to hash out these days at our institution with PE Tract and other ongoing trials as well. But as interventional radiologists, we come into the conversation most often in the submassive and massive patients, and we offer lysis or thrombectomy in these patients. So the lysis devices that we have at our disposal, the picture, the small square picture, that's the unifused catheter. We use a lot of that. It's just a straight up catheter that infuses medication. There's not too many bells and whistles to it, but it's sort of our working horse in many instances in PE care. The ECOS catheter is on the top right, which we just heard about. And the BASHIR catheter is the image on the bottom. And we'll talk more about what makes it special and the rationale for the catheter and the results that have been seen. So the BASHIR catheter is a pharmacomechanical lysis catheter that we've been using at NYU for probably about 3 or 4 years now. We were involved in the initial trial, and we continue to use it today as a part of the PE Tract trial. You can use the BASHIR catheter for PE as well as DVT. There's another similar catheter to this that is specially designed with the appropriate length for DVT management. So the BASHIR catheter is a 7 French system. It goes over an 018 wire, which is kind of one of the sticking points for a lot of us who use it. They're coming out with an 035 version, I'm told, in the next month or so. And you can see the design in this image on the top right. It's a 90 centimeter working length. It comes in a short or a regular basket. And it has the deployment or the basket opening device that is a part of the catheter. And so when you place the catheter and you infuse the medication, that handle remains attached to the patient, which is an important implication that we'll talk about in a moment. And it has an interesting mechanism of action, I think, that kind of builds upon the unifused catheter that we use a lot of outside of the trials. So it's a nitinol infusion basket. There's 6 mini infusion catheters. Each has 8 holes in it to either pulse spray or infuse slowly your medication, which in our instances is TPA. The basket expands at the site of the thrombus, so within the thrombus, up to 45 millimeters. And the thought process there is that as the basket expands with all of these different limbs, it creates fissures within the thrombus and sort of bores a central channel through the thrombus, which allows not only the TPA to instill within the thrombus in a more effective manner, but it also allows blood flow to be restored, allowing your endogenous fibrinolysis pathway to be activated. So the BASHIR catheter, as I've touched on, sort of the rationale is better distribution of the fibrinolytic. You can see in this picture on the lower right-hand corner, the basket creates these fissures into the clot, and the TPA can get inside those fissures. The pulse spray of the TPA will trap clot within the thrombus, again, causing the TPA to hang around longer, potentially work better and work longer. And so what all of this amounts to is a shorter dwell time for patients getting BASHIR catheter lysis with a lower dose of TPA. And if you've got a lower dose of TPA, ideally you've got fewer bleeding complications. So the way I do these cases, you can do them femoral or jugular. I like to do a unifuse case jugular. I think it's a little more comfortable for the patient when they've got a lysis catheter sticking out of their neck for 24 hours. But the difference here is that, and you'll see in subsequent slides, the infusion time is only 5 hours, which means that you can dwell the patient in your PACU and then bring them back and take out the lysis catheters. So you don't have to worry so much about 24 hours of lysis catheters hanging out of the patient's neck or groin. But also, if you recall from the previous slides, you have that deployment mechanism still attached to the catheter that is going inside of the patient's body. So you got to do something with this deployment mechanism. When you go in from the neck, it's a bit cumbersome to secure it to the patient's chest. If you go in through bilateral groin access, it's nice just to have them secured down the patient's leg, and then it doesn't tend to move around, and it's comfortable for the patient as is possible for the 5-hour dwell time. So this is an image of an IJ approach. And what you can see here is we've got a long sheath deep into the pulmonary arteries. And so, you place the sheath in the usual fashion, get your angled pig. That's what I like to use. Sometimes you'll need a Benson wire for additional stiffness to select the PAs. You get the Benson out, Rosen wire in, and advance the sheaths very deep into the pulmonary arteries. And the reason that that's necessary, unlike some other PE work, is that this system is an 018 system. So you've got to get the sheaths very deep so that you can get your 018 system very deep. And then at that point, you've got the stability because of the sheath to get your BASHIR over that 018 wire. Once you retract the sheath, that exposes the basket portion of the catheter, and then from there you can expand and collapse and deliver your TPA per the protocol at your institution. So at NYU, we follow the rescue trial protocol. We'll discuss the rescue trial in a moment. And that protocol is basically you get out with your long sheath, you get your BASHIR catheter in, you expose the basket, and then you do one expansion. You deliver 1 milligram TPA in 10 cc's of normal saline in a pulse spray fashion, and you collapse. You do that again, expand, pulse spray, collapse. Then again, you expand. You do an infusion, 5 milligrams TPA in 500 cc's of normal saline for 5 hours, 1 milligram per hour for 5 hours. So again, it's that expansion and collapse that creates the central channel, that creates the fissures within the clot to allow the TPA to percolate into the clot, presumably encouraging a better action out of the TPA. What that amounts to in a unilateral PE is 7 milligrams TPA, 14 in a bilateral. And during these cases, we do run subtherapeutic heparin. And then once the sheaths are out, we return them to a therapeutic level of heparin. So this is the rescue study that I mentioned previously. It's an evaluation of the efficacy and safety of the BASHIR catheter used to infuse TPA in intermediate risk acute PE. It studied 109 patients in a prospective single-arm fashion across 18 sites in the United States from 2020 to 2022. Patients who were included in the study had acute PE with CT evidence of right heart strain, and the primary endpoint was a change in RV-LV ratio at 48 hours. This is a very common endpoint for a lot of the PE studies for both medical management as well as interventional management. And the primary safety endpoint is adverse events at 72 hours. So What we learned from this study is that there is a significant decrease in the RV-LV ratio by a third at 48 hours, which is substantial. The Miller Index, which is a very complex calculation done by CT, assessing the degree of arterial obstruction in PE patients, was similarly reduced by about a third in these patients. You'll see here the efficacy outcomes, the RV-LV ratio I mentioned, the Miller Index. Something that we always look at is the systolic, is the PA pressure pre and post. And while it did have a significant decrease according to the p-value, I think we can all agree that going from 50 to 44 PA pressures after intervention is not exactly a slam dunk. So I don't think they're really touting that in the study, but it is something to note because I think a lot of us do pay a lot of attention to that. The safety endpoint, very favorable adverse event profile for this product, less than 1% with a serious adverse event, and other more minor bleeding issues were noted. So very low rate of bleeding complications. I provided a chart on the lower left corner just with a few of the kind of main studies on this topic, and you'll see that for the bleeding complications, they too had very low adverse events. So it is a low adverse event rate, but some of the other trials have had very low adverse event rates as well. So really the take home from the BASHIR catheter is that it allows you to use less TPA to accomplish hopefully the same thing as some of the other systems. And so, what's really kind of touted by the company is that what you get here is per milligram of TPA, much more effective reduction in the pulmonary artery obstruction. And if you use less TPA, then you get fewer complications. Another advantage is that it's a shorter dwell time, which is really nice. You don't have to send the patients back up to the ICU. You can just dwell them in your PACU in IR, take out the catheters later that day. It's a lot more logistically less complex in that sense, which is another reason that this product is desirable or is at least appealing. And that's it for me. And I thank you and I welcome any questions.